Please start.
Sure. Thank you, Shubham. Good evening, everyone, and I welcome you again for this academic session that is Decoding GI and HPB Oncology. So, as you all know that we are covering various aspects of gastrointestinal and hepatobiliary oncology in these webisode sessions. And now we have reached rectal cancer. We'll be beginning rectal cancer discussions from today. And today we'll be covering the basic overview approach and surgical anatomy, and as well as the radiological evaluation. So unfortunately, due to some urgent work, Dr. Amit may not be able to join. So I have requested Dr. Prakash sir to have to carry on discussion on that radiological aspect also. So thank you, sir, so much for this urgent request exception. So hi, Dr. Nikhil. So we'll be starting off the session now. And sir, without wasting time, I would request you to take over the stage. Dr. K. Prakash is a senior GI surgeon at Ester Medicity, Kochi, Kerala, and he'll be discussing the overview, approach, and surgical anatomy. So welcome, sir, and you can share your screen for discussion for the lecture. Sir, you are on mute, please. So,
sure.
Yeah.
Sorry.
Thank you.
So,
yeah.
Good evening, everyone. Good evening, Dr. Shivali, Dr. Nikhil, and all the faculties and all senior members who have joined. And first of all, let me thank for giving me this opportunity. So, as I understand, this is a very academic discussion going on. So, my task is mainly to discuss about the rectal tumor. So this from the topic, it appeared that we are going to discuss about the overview, anatomy, and approach. So I haven't included much of the operative part. So we'll go through it. And as mentioned, if there are any doubts, we can discuss in between if it's an urgent thing. Otherwise, we can discuss it through the chat box and clear out the doubts. So, the very beginning, there are a lot of confusion about the level of rectum and the level of different thirds of rectum. And if you look at the literature, you might find little variation between article to article and sometimes between textbooks also. But this is generally which is largely agreed upon. There is no fixed landmark. It's roughly about 7 centimeters the lower third of rectum. It's up to the fingertip. Up to 10-11 centimeters mid rectum, and 15 is generally considered as upper third. And this level is very important in deciding the type of the treatment, particularly when you come to the preoperative chemoradiation. That's why the level is very important. And you might argue what is the difference between colonic cancer and rectal cancer. So as we all know, essentially the treatment principles are same. We should do a radical surgery. We should not touch the tumor, handle the tumor very well. And we should ligate the vessels at the root and do a complete radical lymphadenectomy so that non-block resection is carried out. So that remains the central vascular ligation and CME in colon cancer. It's almost the same in the rectal cancer. But what difference it makes in the rectal cancer is that, as we all know, the pelvis, particularly the male pelvis, is narrow, and the mesorectum goes down to the pelvic floor. And we all know that within the mesorectum there could be nodes, and there could be vascular invasion, and there could be cancer cells. So we need to remove the total mesorectal excision, meaning that complete mesorectum should be excised, and we should strive to attain margin along the circumferential margin. So that makes the surgery a little more challenging, and hence rectal cancer surgery is always considered different, and the results are always different. And to that matter, there was a lot of papers which say that rectal cancer surgery is not superior to open surgery in terms of laparoscopy versus open. But that is a totally entirely different discussion. And now the long-term literature data seems to be almost dealing with that situation, almost negating the differences between laparoscopic and open in colon as well as rectal cancer surgeries. So that's about this is the essence of the discussion today. So we all know that we have the mesorectum here, which is coming down. We have the mesorectal nodes, and our plane of dissection will be here. And as in this old picture, which is a very old publication, we all know that the rectal dissection comes up to the, we should resect the entire mesorectum, and then if you have, we have to keep a sufficient margin. Sufficient margin in a normal case will be around 1.5 to 2 centimeter, and in a pleural differential tumor at least 2 centimeter margin. And in a very low, people nowadays get away with 1 centimeter margin as well, particularly after chemo radiation. So that is a distal margin. And then we should resect the entire thing en bloc and do the anastomosis. So mesorectal excision is the key part of rectal cancer. If you look at the old literature, you can see that a lot of, particularly the data from Swedish area, we can see that they have compared the quality of surgery with TME alone versus radiation, and found that their local recurrence rate is comparable with that those who had undergone radiation in some selected series as well. So surgical radical removal is very much important, and one should do a complete mesorectal excision to get a good long-term results in terms of local recurrence. And this paper you all must be aware of, and I think most of you are have seen the paper. This is the Mri trial paper, which has established the role of preoperative understanding of the disease, the role of preoperative imaging, particularly in terms of MRI, and then the decision upon how to deal with these patients with preoperative chemotherapy and chemoradiation. And we all know that when you talk about cancer, we have circumferential margin, and then we have, if you have the nodes or involvement, as in this picture, you can see that it's node close to circumferential margin. If there is a clear margin more than 1 millimeter, you can still select the patient for surgery. But ideally nowadays, such patients go for preoperative chemoradiation. Similarly, in this picture, these are the public pictures from the original publication. You can see that sometimes the mesorectum involvement can be outside the rectum and coming up to the circumferential margin. If you draw the circumferential margin, if you find that your margin is incomplete, we should select these patients and send them for chemoradiation upfront, so that your results are better. And so the specificity of prediction of clear margin by MRI in this pilot study, when the Mri started, was close to 92%, and the high resolution scans had almost particularly predicted the postoperative biopsy by 93%. So that's a very impressive data. And based on that, they have strict protocol about the pathological specimen as well, how to deal with the margin of the disease, how to do the pathological processing, and how to get the circumferential margin. All these are important in correctly getting the preoperative and postoperative staging, so that you can tailor the treatment according to the disease. And nowadays, the pathologists qualify the completeness of mesorectal resection by complete, nearly complete, and incomplete. Complete means it's not necessary to discuss. It should be an intact and smooth, shiny mesorectum, and there should not be any defects more than 5 millimeter, and there should not be any coning, and should be smooth and regular. That means that entire mesorectal envelope should be covered and should be shiny and smooth. Near complete is if you have minor irregularities, but the muscular scropy at no point of places should be seen, and coning should be very minimal or moderate, and some surface could be irregular. But the moment if you see the irregular mesorectum and the muscular scropy is exposed, or if there is a coning, then it's an incomplete resection. There you have very poor quality of surgery. And we all know that the Mri trial group have published their 5-year follow-up studies, very impressive results. They have clearly demonstrated that with the median follow-up of 62 months, the overall survival in CRM negative patients was 62% versus 42% in CRM positive. So that much difference is there if you preoperatively identify these patients correctly, subject them to the preoperative chemoradiation, then their long-term results as well as the local recurrence results improve by close to 20-25% in this paper. And you can see that the local recurrence rate is also significantly less in such patients. So This results and this large multicenter data from UK and Swedish combined data has clearly established the role of high resolution MRI in preoperative assessment and to judge upon or to select the patients for further preoperative chemoradiation in getting a good long-term results. So this has become the standard of care and probably what you normally call as the landmark paper, which every surgeon should know if you are dealing with rectal cancer surgery. And another important parameter is which are the levels the patient should be selected for radiation. This again is a common dilemma. Believe me, even there is dilemma between clinicians, even with there is a dilemma between oncologists and radiotherapists also when they identify these patients. Particularly when there's a patient who has a long, lengthy tumor which is involving an upper more than the promontory. So, but ideally, the benefit of surgery is maximum when you have the disease below the promontory to the top of pubic symphysis level. So, ideally, we should be selecting preoperative chemoradiation for those patients who are within this range of the pelvis. And coming to the next question, we all know that there are two approaches for radiation, which is short course and long course. And now the debate is almost over. Earlier it was considered as short course, means 5 days of radiation followed by surgery within a week. Nowadays that concept is changing. So preoperative short course chemoradiation patients also wait for about 5 to 6 weeks or even more before taking up the patient for surgery. And long course, of course, is a regime for close to 1 month, and then they wait for close to 8 weeks. And then they do the restaging and then they come for surgery. So this is just a guideline about how to select these patients. Depending upon the stage, this is again, I'll come to that ESMO guideline in the next few slides. So there is something called ESMO or European guidelines, which select the patients into T1, T2, T3, and within the T3 you have T3A, T3B, and T3C. And depending upon that, you can select the patients for, you can tailor down your treatment for the therapy. This is largely agreed upon in most of the papers, most of the groups now. So if you have a T1 or T2 disease, and it's or an early T3A mid-high tumor, when there is mesorectal fascia is clear and there's no EMVI, you can select this patient for direct surgery without preoperative chemoradiation. That's very clear. There's no controversy here. The controversy starts with the T3 disease because NCCN doesn't classify these patients into T3 A, B, C. It's only the ESMO guideline which classifies. So a patient, if there is a T3A, meaning that less than 5 millimeter, 10 millimeter of invasion into the mesorectum, you have clear mesorectal fascia, which is not involved. And then there is no other bad features like EMVI, extranodal involvement. Then again, there is no difference in the long-term results or local recurrence if you have a good quality of TMI. So that patient can be again taken up for upfront surgery. But the moment you have a T3B, or if there is EMVI, or if there is extranodal disease, and if the MRM is not mesorectal fascia is threatened or involved, or levator involved, definitely this patient should go for a chemoradiation, and either short course or long course. Our preference is for always short course because most of our patients have bulky and T3 plus disease, and there the tumor shrinkage, and they're happy with the long course radiation. There are some centers who have tried short course in our country, in our experience also, but somehow we feel that the toxicity and the tolerance level is little less for our group of patients. So we nowadays select these patients for only long course chemoradiation. So typically they undergo the long course chemoradiation followed by waiting for close to 6 to 8 weeks, and then they are taken up for surgery. And if you want to compare between short course versus long term, there are two major trials which are published. You can see that in the Australian intergroup trial and Polish trial with large number of patients, short course 163 and long course 163, with a good follow-up of close to 6 years. You can see that the local recurrence rate is 7.5 versus 4.4, and the overall survival is not that different. Same results with Polish, comparing short course versus long course. There is no difference in the overall survival, but they have noticed that higher pathological clearance rate in long course chemoradiation. So the clearance or the shrinkage of tumor is probably more with long course chemoradiation, but and the tumor downstaging effect may be more. But mind you that both these trials or any other trials have clearly shown a benefit of improving the ability of long course chemoradiation in improving the number of sphincter preserving surgeries. And this is the point which we had just briefly touched upon earlier. This is the NCCN guideline. You can see that they have said that T3 or any node with circumferential margin which is positive, they advise neoadjuvant therapy. So here there is no subdivision of T3 disease, and they should undergo chemoradiation, either short course or long course, and then they are taken up for surgery. Depending upon their stage of the disease, they undergo surgery, and then depending upon the biopsy, they undergo follow-up chemotherapy and then surveillance. That's NCCN recommendation. But the ESMO guideline, which is practiced in most centers, including ours, but we select these patients based on these subgroups. These are the subgroups. So you have the rectal tumor, you have the mesorectal fascia here, and you have the T1, T2, which is either mucosa and the initial muscular layers involved. The moment it comes out of the muscular layers and less than 5 millimeter of mesorectal fascia involvement, T3A, 5 to 10 millimeter of involvement will be T3B, and more than 10 millimeter, still the mesorectum is not involved, is T3C. So you can practically divide these groups into three. You can select these patients as good, bad, and probably ugly, and select these patients for chemoradiation. So those patients with threatened CRM or those with nodes should definitely undergo chemoradiation and then followed by surgery. So this is the difference. You can see that this T1 disease thickening here. The mesorectal fascia is intact. There is no much of lymph nodes. So they can undergo upfront surgery. This typical T3 probably B disease, but the mesorectal fascia is very well clear. So these patients, because of the they can undergo radiation followed by surgery. But if any bulky tumor should undergo high risk group should undergo chemoradiation, then followed by surgery. Then having said that, there are different considerations which come in when the tumor becomes mid and probably close to upper rectum, because the bulk of the disease, as the bulk involves, the staging becomes a little more difficult. And these are few cases. Here you can see that early T3 type of disease. You can see that there is clear. This is the circumferential margin we have. This is the rectal lumen. This is the rectal disease, which just come outside and involving the mesorectum. There is a small node here, which is less than 5 millimeters, so it should not be taken as very significant. So these patients can be taken up for upfront surgery. But if it is a bulky disease, even if it is not causing, here you can see that the disease is quite bulky. It's involving and filling the rectum. But CRM, technically, when we discuss the radiologist also, it is anteriorly it's close, but it's not involved. If you are very careful, you can still get away with the CRM. But the problem with such bulky growth disease is that even if you mobilize fully up to the pelvic floor, you will find it very difficult to negotiate the staples below the tumor because of sheer bulk of the tumor. So such disease, even if you have a almost clear CRM, these patients in our scenario, in a clinical scenario, should undergo long-term chemoradiation. So definitely there will be, you can expect more than 50% regression in the tumor, and if not, sometimes complete response. And then these patients can be restaged and taken up for surgery. Same with the bulky disease here. You can see that when the disease involves very bulky, and if there is an extension of tongue beyond the tumor, these patients should definitely undergo chemoradiation. And then again, the mid-rectal type of growth. So all these patients should ideally undergo preoperative chemoradiation, then followed by surgery. So if you want to have a this is basically the ESMO guidelines. All diseases which are early T1, T3A, they can directly undergo surgery. Other intermediate and low diseases can and high risk group can undergo chemoradiation followed by surgery. Then coming to the real low tumors, there are many terms which are confusing again in literature between low resection, ultra low, intrasphincteric, and other terms. Actually, there is no clear-cut term like ultra low in the literature. You will find hardly any paper describing ultra low resection. It's basically low anti-resection, meaning that the anastomosis below the peritoneal reflection, and below that any level is a low anti-resection. But the moment you come to the sphincter level intrasphincteric, you can divide them into total, intrasphincteric, subtotal, and partial, depending upon the level of the resection. Meaning that if you have a resection plane like this, which is coming up to the dentate line and involving the top of the intersphincter muscle, that's a partial intersphincteric resection. And if you are coming in between the intersphincteric plane, between the external and internal, and removing almost 50%, and it's called subtotal intersphincteric resection. And there is another variety called total intersphincteric. You can practically come up to the skin level and remove all of the internal sphincter muscles and do an anastomosis. I'm not going into the quality of life of such procedures. That's entirely total discussion. But there are a group of patients who would really want to preserve their rectum and try to do all these procedures. So these are procedures which are feasible. And in literature, if you see, there are good number of patients with a good quality of life. But in our experience, it's a mixed group of patients. Their quality of life is not that great. That much only I can say now. And depending upon the stage of the disease, you can divide your intersphincteric dissection into partial onto one side where the tumor is involved. All these are essentially the T1, T2 type of disease, of course. In a bulky tumor, all these are not possible. And anybody with external and internal involvement, they should undergo an abdominal resection. And coming to the few anatomical important landmarks while you do the rectal cancer dissection, you can see that this is a diagrammatic representation mainly highlighting the pelvic nerves. This is the bladder, as we all know, and this is the low pelvis. You have the sacrum here. This is the presacral fascia. The pelvic vein plexus are behind this, and the hypogastric nerve comes in. It gives a rectal branch here, anteriorly close to seminal vesicle, and then enters the bladder. So while you do the circumferential resection, your resection margin is here, and you are supposed to divide the rectal branches here, not to here. Particularly in a young male patient, if you divide here, he'll develop in a lower motor neuron type of nerve transition. He'll develop impotence and probably bladder dysfunction. The same you can see here. You have anteriorly when you come, you have the seminal vesicle, you have the denovillous fascia. The Japanese describe it into 2-3 layers, but most probably at least you should be able to differentiate 2 layers while you dissect. And the pelvic nerves have pelvic plexus gives rectal branches and then go anteriorly. So our plane is the blue line is our dissection plane. One must take care not to go outside this blue line. So this if you take also itself, you are taking complete mesorectal excision without injuring the important pelvic nerves. And these are the different areas at which you can injure. One is at the IMA level, inferior artery level, inferior hypogastric plexus, and then when the nerves cross down to the pelvic brim, and then as you enter the pelvis, the true pelvis, and then the point I described anterior to seminal vesicle, and then anteriorly. So these are the points where we should be careful while you dissect the rectal tumor to prevent an injury. Same picture, you can see that the nerves come like that and gives the rectal branches. So your transition plane is again the green line here. So this is our transition plane. And I'll just touch upon just to emphasize these points and the nerve dissection. I'll just show a couple of small video clips, and then these are the fourth position in our series. And this you can see that the inferior mesenteric artery and probably inferior mesenteric vein. When you dissect here, you have the aorta here, you have the inferior mesenteric artery. We are close to the origin, hardly 1 centimeter. You can see the pelvic nerves getting off here. By dissecting all the lymph nodes here, we should be able to achieve a high ligation without translating the nerve. So you can definitely do a transection at this level, taking out all the nerves. Still you are ligate. Then you go to the inferior mesenteric vein. You can see the ureter and veins dissected, and that once that complete, you have all the nodes cleared, and then you can go on to identify the ureter and the left side gonadal, and then you finally do the mobilization of left column and skin pressure. And this again. And we'll just have a two small videos about the TME aspects as well. This regular TME, after this towards the foot end of the patient, you mobilize the left column to mobilize the spinal fissure. As you come down, you cut the peritoneum close to the pelvic, where the rectal peritoneum joins the pelvic peritoneum, and then you're already below the sacral promontory. And as you stretch, you can see that the nerves getting stretched there, and you should keep the mesorrectal plane intact. And if you do that, your nerves tend to drop down. That's the right nerve and left nerve. So these are the points which you should take care. So still you can see that the clean mesorrectal envelope is kept intact, and we are dissecting the mesorrectal envelope without injuring the nerve. So as you dissect that, the nerves drop down, and then as you go down, you enter the loose areolar tissue plane. You dissect further, and soon you will be entering close to the pelvic floor. So you should dissect out the entire fatty tissue, that is a mesorrectal excision should be complete. At the same time, that's a levator muscles on either side. So posterior dissection is almost complete, and you can see that the lateral dissection is being taken. This is the point at which the nerves come and arch like that. So at that point, you should be, that's a nerve. You can see that the nerve branch comes like that. You should be dissecting here, not too laterally. If you take too laterally, you are likely to injure the nerves. So you can do the dissection completely up to the pelvic floor. And here one should take additional care not to cone. You can see the autonomic nerve parallelly. You cut the rectal branches and leave the nerve intact, so that your nerve injury risk is very less. And you can see that the dissection is almost down. You can see the seminal vesicle, so you are well below the perineal, the peritoneal reflection. Then finally the anterior, because anterior is kept towards end, because generally there is more oozing of tissue fluid and blood from anterior. So this is a layer of de novo fascia. If you are sure that you're about to complete the mesorrectal excision, you can cut the de novo fascia at that level, and then further surgeon is examining the margin adequacy, and then finally you can do the complete mesorrectal excision and do the rectal stapling. So this final bit of mesorectum being dissected. You can see that complete mesorectal fat is being dissected off from the rectum, so the rectal tube is bare, and then you can do the stapling. In this patient, it's done from the suprapubic port, and vertical stapling is achieved through the suprapubic port, and then that completes the translation. Then you can take out the rectum through the fan sterilization, and then plan for the anastomosis. So this is another TME, but slightly lower level. This patient had a very low tumor around 4 centimeters from the anal verge, And here we have done a partial intersphincteric type of resection. So here the mobilization has to be a little more thorough. We'll skip the initial part. And as you can see that the same dissection is being carried out, and the dissection is being carried out to the pelvis. And the entire fatty tissue is being dissected off from the lateral pelvic wall, taking care again not to injure the pelvic nerves. And as you come down, you will be starting to see the contraction of the levator and the muscles. That means that you are in the low pelvis. That's the levator contracting. So you are in the lowermost level. Further, you dissect on either side, and essentially you are taking off all the fat from the levator muscles, so that the mesorectum is completely taken. Now your all around the levator and muscles are exposed, and you are practically at the top of the internal sphincter, the intersphincteric plane. Then gradually with traction and counter traction, if you dissect in the groove between the rectal wall and the internal sphincter muscle, you can get into the intersphincteric type of plane. So you can see that the intersphincteric plane is slowly being dissected. There is a clear plane between the intersphincter and the here you can see that is the internal sphincter muscle, and the plane is being developed. Similarly on the other side. So this has to be done very patiently because one should not perforate into rectum. And you can see that the interdigitating fibers between the rectal wall and the pelvic floor. So you can do a little bit of blunt dissection there to get a margin. And then finally, you are practically in the intersphincteric plane. There's groove. This is the levator and muscle edges, and that is the intersphincteric muscle plane. So that's the intersphincteric plane being developed. And once you are sure that your dissection is complete, then you can start your dissection from perineum, and finally get a margin to get a colo-anal type of anastomosis. So and then you can deliver the specimen if it's not bulky from below, or use a long star retractor and do a colo-anal type of anastomosis, and that completes the procedure. So this much was now overview. We can discuss anything more in the discussion points. Any points if I have missed, I'm happy to clarify within my limits, and others also can pitch in. Thank you.
Sure. Thank you so much, sir. Very clear and concise discussion about the whole overview. So there are a few questions in the chat box. Dr. Shabnam Bashir has asked, so excellent presentation, sir.
Thank you. Thank you.
So she has two questions.
Yeah, please.
TME for rectal cancers, the TME onto pelvic floor for rectal cancer, the fold with no tumor at ink margin acceptable. For TME onto LA muscles for all rectal cancers.
Can you repeat that? I didn't hear that very well.
Yeah, so you can see the chat box also, sir. So the question is, are you doing tumor-specific TME for rectal cancers above the peritoneal fold with 5 centimeter distal margin being sufficient, and TME onto pelvic floor for rectal cancers below the fold with no tumor at ink margin acceptable, or TME onto LA muscles for all rectal cancers?
Yeah, for those at the level of peritoneal reflection and below, it's always TME up to the pelvic floor. We do the partial resection only in upper, maybe the uppermost middle tumors only, where we try to get at least 5 centimeter partial mesorectal clearance. So all other patients will undergo a total mesorectal excision.
Okay. And do you prefer early surgery after SCRT or prefer to wait till 8 to 10 weeks?
No. Actually our experience with short course is very less. We have tried for only few patients. But somehow we had some complications like bone marrow toxicity, as well as unexpected type of gross anastomotic issues. So we have stopped doing that. So our policy is to give long course for all patients. We are not using short course, except for few patients who had say, specific instances, like patients. I can remember a couple of patients who had cardiac issues and they had to undergo stenting or CABG before surgery. So they had to do the chemo radiation, then go for the cardiac procedure, then come back for surgery. So those were specific instances where we use short course. Otherwise, it's always long course. It's a long course followed by waiting time up to 8 weeks.
Right, sir. And up to which level is sphincter preservation possible in anorectal lesions? Dr. Roshni has asked that.
That again is a very subjective question. I would say it depends upon the stage of the disease. If it's an early disease like T1, T2, or early T3, you can practically preserve the disease environment up to the level of dentate line, meaning that the lesion should be within say 4 centimeter from the elbows. We can do a partial intersphincter resection and do the preservation. So if it's, but at the same time, if it is a bulky tumor, even if after radiation you have a lot of fibrosis, and it's very difficult to judge on table. Like today itself, we had a young patient who had a response apparently, but the posterior lateral pelvic wall and that part of levator, and there was fibrotic reaction. So I was not sure whether we were dealing with the tumor. So we had to convert that patient to APR, despite being 27-year-old patient. So it depends upon stage of disease. It depends upon your assessment. But theoretically, you can do a good partial intersphincter resection up to lesions up to 4 centimeter, provided the staging and other factors are good. And yeah, that's it.
Yeah, have Indian experience. So, Dr. Sandeep Barik, so we are doing TNT at Max Saket, and we are following both of the approaches like CTRT followed by chemotherapy and then surgery, or other way around, that TNT starting with the chemotherapy followed by radiation and then surgery. So, I would ask sir also if they are practicing TNT protocol in CA rectum in locally advanced lesions. Sir, at your center, are you practicing TNT type of protocol for lower and mid rectum cancers for locally
No,
advanced lesion?
no.
Okay. All right. So, comment upon TNT experience.
What's your experience? What's your take on that? I'm curious.
Yeah, so that is why I wanted to have Dr. Nikhil. So we recently started practicing TNT protocol. Are doing total neoadjuvant treatment in those patients who have who we feel on MRI, or cases who have a locally bulky disease and we want to downstage as well as systemically give a good control. We are practicing in them, and though we are debating day in day out in our tumor, what approach is to be used, whether to start chemo radiation first or chemotherapy first. We are practicing either of them, still, which we can say okay is better over the other. So we recently followed the updated presentation of that TNT protocols, which says that in terms of the overall survival or the long-term DFS, both are equivalent. However, PCR are better with to start with the chemo radiation. So still long way to go before we conclude our experience in terms of data, but the patients whom we have started on TNT, we are seeing good resection rates, and in couple of them very good PCRs also. Dr. Nikhil, would you like to comment upon? I don't know whether Dr. Nikhil.
Yeah, Dr. Sefali, can I add something? This is Dr.
Dr.
Sandeep.
Nikhil, are you there? Yeah, please, sir. Please.
Yeah, actually, we are conducting a
Can
RCT at AIIMS Bhubaneswar, where we are doing long course versus TNT. So as of now, 18
Right.
recruited patients. Out of 9 in TNT, we have almost 45-50% with PCR, and that were almost T4A, T3,
Right.
T4A. So early start is good, but let's see what the long-term results are.
Absolutely. I completely agree. We have also similar kind of experiences, and we have approximately 10 patients, I think, because we have started using TNT recently. And I think it's conclude the data, but experience so far is good. Yeah.
But the
So Dr.
problem with such patients is the postoperative assessment. When the tumor really regresses and becomes an ulcer or a scar-like, what are your protocols to assess these patients on follow-up? This
sir,
is our common
I think we missed your
issue.
voice.
No, when the tumor has regressed and become an ulcer-like or scar-like area, it's very difficult to follow up and do the follow-ups of these patients. So, what is your protocol in follow-up after the therapy?
We are not able to hear you because of some network issues.
Okay.
We missed that thing which you mentioned.
Okay.
So what we are following, if we start with the total neoadjuvant in terms of chemotherapy, so we are doing MRI every 4 to 6 cycles. So if there is a good response, like a couple of patients of ours had a near complete response, so we complete total chemotherapy, that is 9 cycles to 12 cycles, depending on whether we are following rapido versus prodage. So we complete all upfront and then go for chemo radiation. However, in some patients where we see that there is a stable disease and not of a much response, then we discuss in the tumor board and plan either for long course chemo radiation or the short course upon, preferably long course in that scenario where we don't get a very good response on chemotherapy in the TNT. So Dr. Sandeep, what kind of follow-up protocol do you have once you are planning for a TNT?
We exactly do an MRI, but after 3 cycles we do an MRI, and after 6 cycles also do an MRI. And
sure. So we'll be taking that whole session of discussion in I think next one whole session of discussion on neoadjuvant approaches in rectal cancer. So I think I would be happy if you can join at that point of time. It will be on 3rd Wednesday, and we can have a full discussion on neoadjuvant approaches. So, sir, a couple of questions. If any, if you would like to answer or any would like to add on. So there are sometimes the invasive cancer, what we find on adenomas over and above that. So it's very difficult sometimes to evaluate them. So what imaging modality would you use? MRI, CCT, or EOS, TRUS? How do you go about it? It's very difficult sometimes to make a decision. And even on a small rectal polyp, which sometimes, or endoscopically get removed and you do not have anything to comment upon. So how do you proceed in such cases? So Dr. Prakash, if you can take.
Yeah, after say you're talking about endoscopic mucosal resection and then follow up with the base involvement.
Right.
That's a very difficult group of patients because of the scarring.
Yeah.
Further endoscopic ultrasound assessment is very difficult. Yeah, what we still follow is to do periodic MRI and of course scopy surveillance. But EUS in that setting is very difficult because of the inflammatory reaction to follow it up. So essentially it's MRI and frequent sigmoidoscopies.
Right. So Dr. Shabnam, you would like to comment upon, because you recently had a very good conference on rectal cancers. So anything you would like to add on this area actually?
And the first, Dr. Sandeep was asking about the experience on TNT. TMH is probably running a study, and Dr. Reena Engineer is probably also considering intraluminal brachytherapy for these patients to have a complete response. And second, the majority of the times, the issues that we are having are multiple tumors with high-grade dysplasia, which have been removed piecemeal, and we don't have any report on the base. And sometimes the patients are from other high risk, not high risk family history, but other high risk factors. So it becomes very difficult, because there's no proper recommendation or consensus on what should be the exact follow-up for these patients, or the frequency of the follow-up. And you tend to give them, weigh the risks and benefits and count the risk factors, and then tend to, do we have a consensus if we have a piecemeal removal of more than 1 centimeter polyp with high-grade dysplasia? What should be the exact follow-up for those patients, and what are the different centers recommending?
Yeah, I mean, that is very important questions, and we are discussing in our tumor boards how to evaluate them further and how to follow up. Dr. Nikhil, any comments on that?
No, Dr. Shefali, I'm so sorry. I actually lost my speaker and mic both suddenly, so I wasn't able to hear.
Yeah, so we were searching for you in between.
Yes,
no
yes.
worries. So we were discussing that the difficult to treat patients, like patients who come to us after getting a polypectomy done, and where we do not know what was the invasion, or how do we evaluate them, or cancers developing in the adenomas already. So how to evaluate those patients, follow-up protocols, I mean, how to do that?
So very difficult. I can only say anecdotes, patients which we have treated like this. So I remember a young boy in whom similarly a polypectomy was done. It was reported as adenocarcinoma, rectal examination, sigmoidoscopy, everything revealed normal. And we didn't knew where the polyp exactly was, what was the lower margin. So when we imaged, we found a mesorectal lymph node. Right, and since lymph node was there, so we just went ahead, gave him neoadjuvant, and did a ISR on intersphincteric resection on him later. So it's a very tricky question, and if what data we have, like if the clinician who have done that polypectomy has noted the lowermost extent of the tumor or not noted, and even if the endoscopists have noted the lower extent, that is most of the time unreliable. So one, we have to judge the distance by digital rectal examination, and 2, MRI. And these two things are not available. So it's a very, very difficult proposition, and a lot of guesswork will be involved, and we will have to individualize the treatment. So I don't think a blanket recommendation can be made there.
I mean, it's a wild thought, but we have a lot of role of ICG actually in looking for the vascularities and all, or chromoendoscopy.
From any of the faculty or any of the people who have joined, that how do you rely on and how confident rely on MRI to report a very small lymph node if you have an early, say, T2 tumor otherwise, and a small node is just near CRM? How do you take it? Because I mean, it's very difficult to make a decision whether which patient would require an intent type of treatment versus where we can do upfront surgery in some of the patients. So do it over and above MRI, or I mean, how confident are you on your radiologist, or for that matter, decisions to go for upfront surgery versus a neoadjuvant?
So before you ask this question, Dr. Shefali,
and then if anybody else can like to comment upon.
Dr. Shefali, before you ask this question, I will ask one question to Dr. Prakash. Sir, would you follow the Western guidelines? I mean, sorry, Western, no, European guidelines, especially that chart which you showed from European guidelines, or the American NCCN guidelines in treating? There is some discrepancy there, and which one do you follow?
Yeah, that I had told we follow the ESMO guidelines.
Does that matter?
Meaning that
ESMO guidelines, correct.
T3 will be subdivided, and we'll be selecting these patients for chemo radiation based upon the T3 A, B,
so,
C status.
Yes, and the major difference which I find in these two guidelines, so ESMO guidelines are very much focused on CRM.
Correct.
Up to middle rectal cancer. So they say if your CRM is free, then you can go ahead with the upfront surgery also. So they are not very much concerned about the node. Correct me if I'm wrong.
Yeah, they do. They mention about the vascular invasion and of course involved looking nodes. Not for all.
Sir, they said if the node is free, I mean, away from the CRM, you can go for surgery.
Yeah, then we can, accept.
Right. But the NCCN will say that any node positivity, they will advise neoadjuvant approach.
Correct. So
right now, the question which Dr. Shefali is asking is the same thing. Basically, like if the node is there, how would we go about it? Because we can never say a node is positive or not on imaging. Right. I mean, we can see a node, but we can never say it's positive or not. And I remember reading a study where they have done some data analysis, and they said that a positive looking node on imaging is positive only 50% of the time. So the question to answer to your
Dr. Nikhil,
question,
there are some studies also. I mean, I would like to highlight, if you can comment upon. So they say if the part for the characteristics of the node, what we discuss on radiology, most of the time, if the tumor is 8 mm or above, it is 42% of the time that it is likely to be positive node. So, I mean, what is the cutoff? If we see on radiology, what is the cutoff we take for the node, and what are the characteristics where you say with confidence, okay, this is likely to be a positive node and we should go for a neoadjuvant upfront?
So there are, I have a slide there, just a sec, just give me a moment. So I'll just tell you the radiological criteria of node positivity.
Yeah.
Just give me a moment.
And till the time you take out the slide, I would like to request sir to highlight what exactly on MRI from a surgeon's perspective you all want to know. That, okay, these are the details which are must, these are if they can help us, and these are which are not necessarily. So 1, 2, 3, 4, 5, sir.
Yeah, of course, the circumferential margin, the CRM. And second, the node, how we look at it, we have our tumor board and discussion with radiologist. We take 5 millimeter as the, and the size of the shape of the node. And then any node close to the CRM, that again also is taken into consideration. And then finally, the vascular innervation features. So these are the 4 features with which we decide the patient for neoadjuvant versus non-neoadjuvant. And having said that, there are some Japanese data which are about to emerge. They have even a study going on comparing upfront surgery irrespective of the T3 disease. And the study is about upfront surgery without chemoradiation compared with those with lateral pelvic lymphadenectomy in those with T3 node disease. Probably such studies, when they come out, we'll get a totally different perspective on that, because all these days, the issue of the assessment of the CRM or the quality of surgery and the meticulousness of surgery is not correctly being addressed. When such a Japanese data comes out, I think we'll get probably a much better idea about how important is the complete TME and meticulous dissection in such patients.
Right. And where do you think that the role of number one EUS comes in evaluating the rectal cancer when we have a good quality MRI, and where do you place the PET CT in line of approach of evaluation for the rectal cancer, sir?
In rectal cancer, the EUS comes in only with the polypoidal small lesions where you are contemplating either a local resection like a T1 disease, or those with say when you have a flat type of lesion sometimes where you are planning for a very low resection, interspecific type of resection. So 2 areas. Otherwise, EUS has no big role in the upfront decision. Maybe
Right.
if you have a patient with who has completed the adjuvant therapy and then has a scar-like issue, then probably EUS might come in along with MRI to assess the disease. And then PET is always if you have features like high CEA, or if you are suspecting an advanced disease. Otherwise, for assessment of rectal cancer per se, PET has no major role unless you suspect an advanced disease or a metastatic disease.
Right. So, Dr. Nikhil, have you come up with your slides? Dr. Nikhil? Dr. Nikhil? I think Yeah, I'm not audible. So carrying forward the discussion, sir.
So Dr. Shefali, you wanted to know about the nodes. So
yeah.
MRI criteria. So I mean,
Yeah, please.
yeah. So it says malignant characteristics, right? So it's indistinct, heterogeneous, or round, right? And all these three, indistinct, heterogeneous, and round, are malignant characteristic of a node. So if a node is less than 5 mm, then it need all three for them to be categorized as malignant.
Okay.
If you have the host right, Dr. Shefali, unmute somebody who's making that sound.
Okay.
Then 5 to 9 mm node, you need 2 malignant characteristics, and more than 9 mm nodes are always suspicious, irrespective of malignant characteristic.
Right.
Right. So this is how you characterize nodes or classify nodes on MRI.
Right. Right. And one more question. So most of the time we see that patients come to us after getting evaluated outside, and sometimes the full colonoscopy is not done. So what would you say? What is the role of full colonoscopy while evaluating a patient for rectal cancer? For the student's sake, I think it should be clear. So what is the role of full colonoscopy? So Dr. Prakash, if you would like to take on that questions, or anybody else?
Yeah, I think an attempt should be done to do a full colonoscopy unless the tumor is obstructing before surgery. Otherwise, in the postoperative period, it could create sometimes confusion when you see do an imaging or a scopy later on and find out another lesion. That will be always confusing. If she will be only in those with nearby obstructing tumors, it will be very difficult to do that procedure.
Right. Right. So, Dr. Nikhil,
yeah. Can I chip in?
Dr. Shabnam, yeah, please.
So our protocol has been, if the complete colonoscopy was not there, since there is still 5 to 10% chance of having a synchronous lesion. So immediately once the chemotherapy is over, after the first follow-up, we do recommend usually to have a complete colonoscopy, to be sure what we're dealing with.
Right.
Absolutely.
Yeah. All right. So any other
do we have any
questions,
radiology? Dr. Shefali, do we have any questions?
I think in the chat box there is none which we have not taken up yet. So,
can I just ask one, if anybody is, there's always been a talk about the CRM positivity and our approach to the disease based on that, and whether we are doing SCRTs or CRTs. How do you evaluate your patient or base your decisions if the tumor itself is threatening the CRM, or if it's just a node which is very close or threatening the CRM? Does your approach differ in these two categories?
So, I mean, if the tumor or the node is threatening the CRM, especially in the lower and mid-rectum tumors, so I think our approach is towards the neoadjuvant approach rather than going for an upfront surgical resection. So again, Dr. Nikhil.
So I think Dr. Shefali, what she's asking is like neoadjuvant you are giving, but will the approach, see now there are multiple ways we can give neoadjuvant. So one is the standard long course scheme.
I was coming to that. So like I told you initially also, so we are yet to streamline whether to approach a neoadjuvant chemotherapy versus a neoadjuvant chemoradiation approach. So I think if it's like a bulky tumor, so we we see the great heavy nodal burden or the soft tissue deposits. So I think we have a couple of patients where we have started on neoadjuvant chemotherapy approach first rather than a chemoradiation. However, if it is the nodal burden only or the tumor is not causing the symptoms locally, so then we have started few patients on chemoradiation itself as a protocol. So however, this is not streamlined, I would say. Dr. Nikhil,
I would say, Dr. Shabnam, specifically to your answer, that if node is threatening the CRM, I would go for standard neoadjuvant. What we generally for us, the standard is long course chemoradiation. And if the tumor is threatening CRM, it means it's a bulky tumor. I would want a significant downstaging there, and I would probably opt for a TNT in these patients.
Right, absolutely.
Right. So then we have one more question here. Can we go for upfront surgery in patients with tumor above peritoneal reflection, irrespective of nodal status and CRM involvement? Dr. Prakash? Is he still around?
Yeah, sir, please unmute yourself. Yeah.
I just missed that question.
Tumor above peritoneal reflex, can we go reflection? Can we go for upfront surgery irrespective of CRM involvement and nodal status?
Yeah, tumor above the peritoneal reflection up to the upper rectum only we have the neoadjuvant protocols in place. Otherwise, it depends upon the stage of the disease. If you want to downstage the disease only, there is a role for neoadjuvant. Otherwise, you can go for upfront surgery.
Sir, in the tumor in the upper rectum above the peritoneal reflection, if it is a T4A disease, or I mean, would you like to go for a TNT type of protocol with the chemotherapy, or do you still prefer a radiation type of protocol in upper rectal in locally advanced tumors?
No, if it is if the radiotherapy can be safely administered, definitely radiotherapy comes in there. But as I said, there could be some tumors which are sometimes elongated, which can go up to the rectosigmoid, up to the mid rectum. In such patients, it's very difficult to include the entire length in the radiation field. I'm talking about such patients. In such patients, it's really difficult to judge. Otherwise, if it is whether the radiotherapy can be safely administered, definitely neoadjuvant protocol followed by surgery.
Yes, I think yes. But sir, like nodal positivity in upper rectum will not call for neoadjuvant.
It's all, I would say it's all depending upon the oncologist combined decision, but most often they go for neoadjuvant, yes.
So for peritoneal reflections, any tumor above the peritoneal reflection, actually the term CRM in true sense cannot be applied because it's just the serosal disease or non-serosal disease.
So Dr. Shabnam, CRM can be applied because posteriorly you have the CRM.
Yeah.
Upper rectum, posteriorly you have CRM, anteriorly you have the serosa. So that's why you have this T4A coming in there. So if there is anterior involvement, it's T4A. And if you look at the ESMO guidelines, T4A is considered in the neoadjuvant group. So T4A, you should give neoadjuvant. That's what they recommend.
Yeah. So, Dr. Nikhil, T4A, we are in upper rectum. Where do we stand? So, are we again approaching a CTRT approach or a neoadjuvant chemotherapy?
So, we don't have any data against it. So, I mean, so far, we will follow the neoadjuvant approach, T4A. T4A,
right. Like other mid and lower rectum tumors. Right?
Yes, yes, absolutely.
Right. And there are two more questions if you can take up, Dr. Nikhil, in the chat box.
I am doing it from mobile, so just a sec. If you think
so Dr. Rudra has asked LVE, any change of plan?
LVE means?
I do not get it. So I thought it's
Dr.
a surgical
Rudra,
term.
please,
So any surgeon can take it out. Yeah.
Yeah, I think this is very pertinent in latest MRI. They are able to diagnose venous emboli.
So, okay, lymphovascular emboli you are asking.
Yeah. So if you find it, it is almost like it will look like a node, but you can trace it to the vein. So in these kind of cases, I think newly described as a TNT should be followed.
Dr. Rudra, what you are telling is absolutely right. ESMO guidelines considered EMVI as a risk factor, and they use it as a criteria for neoadjuvant. So any patient with EMVI will go for neoadjuvant treatment. Now there's a question from Dr. Shraddha. If we take up the intermediate group for upfront surgery following the ESMO guidelines, do we routinely go for post-op RT? Dr. Prakash, you would want to answer that?
Yeah, that's you are talking about your preoperative imaging and the postoperative staging are totally different. If the staging comes almost similar to your preoperative assessment, then this patients may not require radiation.
Yes,
Suppose,
absolutely.
Yeah, that happens with the current day good MRI. Such major changes in the staging is very unusual.
Right. So I think there are no more questions. So I think we can wind up.
Can conclude.
So,
Yes, yes.
yeah, we can conclude. So I thank you all for taking up time and contributing to this academic session. Thank you so much. So making this session very interactive. So we would be taking up the neoadjuvant approaches in the next session, which will be on the third Wednesday of this month. So we'll circulate the agenda sooner. So thank you all, and request you all to join in future sessions also. Dr. Nikhil, you can give the
Yep, thank you. That's it. So next is multimodal approach, and we expect to have there's one more question, I think, somewhere chat. No, it's thank you. Okay, I think we can conclude. Okay, okay. Thank you. Good night, everyone.
Thank you.
Thanks for joining.
Good night, everyone. Thank you.
Thank you.